Hello students, and welcome back to another lecture about drugs. In fact, today is your last lecture about drugs, and today we are going to talk about the worst and the scariest drug of all. So as I said in the beginning of the semester, my plan was for us to work our way from the smallest, least offensive drugs to the hardest, scariest drugs, and that's why today we're going to talk about opioids. Our first question, of course, is what is it? And that's a great question for this drug because technically the word opioids is kind of an umbrella term for a whole class of drugs, all of which are made from the poppy or sort of chemically copying the drugs that are made from the poppy. So what we're going to do is take a quick historical overview of all the drugs that we call opioids and how we've used them over the course of the last several thousand years. So first, let's look at a short timeline. Humans have been cultivating the poppy plant for thousands and thousands of years. We first saw it in ancient Mesopotamia, and from there it pretty much spread all over the world. So we have a lot of evidence of the poppy plant being turned into opium and being turned into various opiates over the course of hundreds of years. So first we're going to talk about the 1800s. Basically what happened was they made opium into morphine, especially to treat people who were going through surgery or people who had recently been in surgery. This was aided by the invention of the hypodermic needle, which didn't happen until 1850. Then, in the 1900s, they transitioned from just making morphine into making a stronger form, which was heroin. In about 1950, they invented an even stronger form, which was fentanyl, which we'll talk about today. And from there, they sort of started to back off and invent lighter, more sort of palatable drugs like Percocet and Vicodin. And then in the 1990s, when they noticed that people were really struggling with the abuse of this kind of drug, they invented the time-release capsule, which of course people immediately started to abuse. That leads us back to the 2010s, which is when people who were already addicted to the pill form of the drug switched back to the heroin form of the drug, which again is one of the things we'll talk about today. So basically, it all starts with the poppy plant, and from there it gets more and more complicated. The main drug we're going to talk about today is Oxycontin. So Oxycontin is just one drug, produced by just one company, but it's had a sort of outsized impact, especially in America. So we're going to talk about this specific drug a little bit in regard to how it got everywhere and ruined so many things. So basically, as you saw in your book, it was released in 1996, and the idea that they had that was unusual was that it would have a time-release formula. So instead of addicts being able to take all of it at once, they would have it gradually distributed throughout their body. And this was ideal for people facing chronic pain because they didn't have to spend all day taking pills. They could take one in the morning and one at night and live their lives. But the thing that was really important about Oxycontin was the marketing. So they talked about this a little bit in your book, but I wanted to show you some pictures. So first of all, you may recognize this dude. It's Rush Limbaugh. He's the worst. And he was actively addicted to Oxycontin for quite a while, which finally he did come out and admit. But basically, they used people like him, who were considered to be trustworthy or who were popular in the media scene, to advertise this drug. And that made people trust the drug. They also heavily courted doctors. And this is a very important part of the Oxycontin process. They spent a lot of money giving swag to doctors, like that CD that was mentioned in the book, and of course this gorgeous hat. And they spent a lot of money giving lunches to doctors and sending pretty women out to talk to doctors and having their Oxycontin meetings in glorious tropical places. So basically, the thing that Oxycontin did that was different than everybody else was marketing. The problem, of course, is that as prescriptions went up, so too did addiction. So as more and more people got prescriptions for Oxycontin, more and more people got addicted. So we started to see things like this sign in the front of the pharmacy that says that they don't even carry Oxycontin because theft was a huge problem for a little while. And we also started to see things like in this next picture, where the company tried to change the formulation of the drug so that it would be more difficult to grind and shoot. This was important, but it still didn't stop the huge rates of addiction, and it didn't stop people from turning to harder drugs. Which brings us to our next scary drug, fentanyl. Fentanyl is not our main topic of conversation today, but I wanted to talk about it just a little bit because it's become incredibly present in overdose deaths. Fentanyl is one of the most powerful drugs that we have invented, like as a species, and just a tiny little amount will absolutely kill you. literally the size of a few grains of salt. So what we've begun to see lately is that fentanyl is mixed in with other opiates, in part to make them stronger or to make them go a little bit further, and we're seeing it have an incredibly negative impact, especially on opiate users. Our next question is, what is it used for? And the answer with this one is a little bit complicated and very important, because basically opioids are used to control pain. They're incredibly effective in terms of pain management tools. But the other thing that opioids do is that they provide a sense of euphoria in the brain. So typically they're used for people who are in pain, but also they're panicking. So people who have recently experienced surgery, people who are surprised to be waking up with a terrible injury, people who are experiencing end-of-life care, because not only does it calm your pain, it calms your mind. And this is a major part of why people become addicted to opioids so quickly. This leads us into our next question, which is, what does it do? And again, we're not going to get super into the biochemical aspect of this, but basically, it blocks pain and it makes you happy. So let's look at these next two graphs just to get a quick idea of what it does. In this first graph, we're seeing a pretty bad cartoon drawing of how the brain understands pain. And basically, the pain signals travel through your nerves into your brain cells, but they can be blocked by opioids. So essentially, it gets in the way of the pain signal and blocks it from reaching your brain. So you're still experiencing pain, you just don't know about it. The other thing it does that's very important is that it heavily stimulates your dopamine system. And one of the things that we've talked about over the course of the semester is that brains love dopamine. There's nothing your brain loves more than dopamine. And so one of the things that the opiates do is just flood you with dopamine. And again, that's why they're so addictive. So how does it work? It takes away your pain and it makes you happy, and that's all humans really want. Our next question is where things start to get really interesting, because our next question is it medicinal? And the answer is yes. That's kind of the whole problem. It started as a medicine, it's understood as a medicine, it's prescribed by a doctor. So for a lot of people, they don't think this drug is dangerous because it comes from a doctor, very much like Ritalin, which we talked about earlier. The problem is that it is useful in medicinal situations, but you're only supposed to use it for a little while, and you're only supposed to use a little bit of it. When people continue to use it after their physical pain has passed, or when they grow a tolerance because they've been using it for so long, that's when the abuse starts, and that's when we really start to see an issue. So if we look at this graph, this is a graph of why people started taking this drug. And as you'll notice, the main reason is pain. And that's perfectly sensible. This drug is for pain. But if you continue to take this drug after your pain has passed, or if you continue to take more of this drug because you've developed a tolerance, we start to see more social and psychological issues for the reasons that people are doing this drug. To feel good or to get high, obviously very popular. To relax or relieve tension, also very popular. Some people take it to help with sleep, and the other reasons are largely social. People are experiencing too many emotions and they would like to stop feeling them. People are experimenting to see what all the fuss is about. People want to see why other people are doing it at parties or in rap songs. All of this is relatively understandable. So is this drug medicinal? Yes, but the abuse of the drug is not necessarily medicinal, and that's where the problem comes in. Our next question is, how much is consumed? And the answer to this one is a lot. A lot. Just so much. Much more than would be rational for the treatment of pain. And that's part of how we know that it's a real problem. So one of the things that's really interesting about this drug is that in America, doctors are writing about 6 million, maybe 7 million prescriptions a year, but that isn't the same thing that's happening in the rest of the world. So if this drug were being used solely for pain management purposes, we would see a relatively even rate across other places in the world. But the fact is that in America, we are using it a lot. So let's look at some graphs. In this first graph, we're looking at how many prescriptions are written in America than in other countries. And you'll notice that the answer is more. United States is far and away the leader in regard to how many opioids are prescribed for every 1 million people. You might notice that most of the other countries that tend to see a lot of use of this drug are also first world countries. In this map, we see that even within America, some states have more prescriptions than others. And one of the things that you probably noticed in your book, or you might have seen in other media about this drug, is that again, it's very popular in rural areas and Rust Belt areas. So much the way that we saw meth become really popular in places where the jobs have all gone away, we see opiates become really popular in the places where either the jobs are really hard or there also are no jobs. So again, it's much more commonly seen in poorer, more rural places than it is in other like wealthier or perhaps more urban places. So that's another way that we know that it isn't distributed randomly, it's distributed according to specific sociological factors. In our final graph, you can see that over the course of the last 17 years or so, this data is a little bit old, opioid prescriptions rose heavily, but then started to decline. And the issue here is that we don't think that people are using fewer opioids. We think that people are supplementing their addictions with things like fentanyl or heroin. So they're still abusing opiates generally, they're just not abusing the ones that were prescribed by their doctor. So this kind of graph can be a little bit misleading because we think that opiate use continues to rise. It's just that a lot of it is purchased illegally, so we don't have that data. Our next question is, how much do we spend? And as always, this question kind of exists in two parts. How much do we spend on the drug, and how much do we spend on people doing the drug? So we're going to start with how much do we spend on the drug itself. So again, one of the things that's important to note here is that this is a prescription drug. So in a lot of ways, it's a little bit easier to track. So let's look at this first graph. This graph is looking at how much Americans spend on prescription drugs, period. So this isn't just opiates, but as you can see, in the 90s and the early 2000s, there was a huge jump, and that was opiates. So Americans are not spending more on other prescription drugs, they're spending more on this drug. In the second graph, you can see that they're comparing the price of the medicine in Canada versus the United States. And the reasons that it's so different are part of a whole nother class, but just trust that healthcare is much more expensive in the United States than it needs to be. So if we look at the bottom right of this graph, you can see the price per capsule or per tablet. And as you'll see, there's a huge range. It ranges from about 4 cents to about $14. So this is part of why the addiction to the drug can be so dangerous. The heavier dose you're taking in terms of the strength of it impacts how expensive it is, and the further and further you go, the more and more expensive it gets. The other part of this question is how much do we spend on the people who are on the drug? And again, this gets very complex because we're looking at not just arresting the people and trying them, which creates a lot of cost, but also treating the people. We tend to see a lot of overdoses come into hospitals or be treated by EMTs right on the street, and this gets very expensive. So essentially we think we're spending about $500 billion total, but it could be more per year on people who do opiates. So if we look at this next graph, it might help a little bit to clarify things. This graph is measuring the economic burden of opioid abuse. And so basically here they're looking at things like health insurance, which absolutely is expensive, and of course health care, which is very expensive, but also lost productivity, criminal justice, the price of incarcerating these people, and substance abuse treatments, which only account for 4% of our spending and should probably account for a lot more. But the basic premise is we are spending a lot trying to take care of people who already have this addiction and trying to help people stop having this addiction and stop committing the kind of crimes that are caused by this addiction. So in a lot of ways, this is a very expensive drug. Our next question is it harmful? And the answer is yes. Yes, so harmful. Really one of the most harmful drugs, again, that we have invented as humans. Part of the reason it's so harmful is that if you take too much of it, it essentially slows your lungs down until they stop, which then turns off your brain for, again, a very low-level explanation. So it does kill a lot of people every day, and it can kill you the first time you use it. So in that regard, again, it's a little bit unusual in terms of how harmful this drug is. So what we're going to do is look at a couple of graphs to sort of examine how harmful it is and the impacts that it's had on America overall. So let's start with a graph that is very easy to understand, which is the relationship between opioid prescriptions and opioid overdose deaths. So as you would imagine, as one goes up, so too does the other. They're getting a little bit further apart in regard to the deaths being a little bit lower than the sales as the course of history goes, but again, we think that might be due to illegal use. Speaking of which, in this next graph, you can see 3 waves of the rise in opioid overdose deaths, and this tracks quite closely with your book, because the first wave is prescription opioid deaths. This is the Oxycontin. The second wave is heroin overdose deaths. This is the people who became addicted to Oxycontin and switched to heroin. And the third wave is synthetic opioid deaths. This is people who started having fentanyl, or sometimes tramadol, mixed in with what they thought was just heroin or Oxycontin. In this next graph, we're looking at some relatively old data, but I wanted to show it to you because it draws a very clear correlation between not just race, but also age. So here we can see that a lot of the prescription drug deaths occur in younger or middle-aged people. Again, this is relatively common because if you're just taking the prescription drugs, if you're just taking Oxycontin, that can take a couple of years before either you build up your tolerance or you switch to something more dangerous. But if you're taking something like heroin or obviously fentanyl, that'll strike more quickly. So here we see that it's especially common in white people, especially relatively middle-aged white people, but there's also a disproportionate amount of death in the American Indian and Alaska Native community, and of course in the Black community. So even though most of the people who are taking and dying from this drug are white, a disproportionate amount of the people are Native Americans or are Black. In this next graph, we're looking at drug overdose deaths of several different drugs, but again, I wanted to show it to you because it shows the outpaced effect of opioids. Opioids are represented here in blue, and you can see the extent to which they are basically the #1 killer in 2016 among overdose deaths. Other drugs are making a pretty strong showing in terms of prescription opioids, heroin, and of course synthetic opioids if you break them down smaller than that. But I wanted to be clear that opioids are the main thing that is killing Americans. In this next graph, we're looking at overdose deaths by gender. So here, men are represented in gray and women are represented in orange, and you can see that there is a gender correlation, which is to say that more men die from opioid overdoses than women, and that holds true longitudinally from 1999 to 2018. In this graph, we're looking at opioid deaths broken down by county. And as you can see, it is spread out pretty well over America. There's a lot of different deaths caused by a lot of different forms of opioids, but it is much more concentrated in certain places. And the specific drug is more concentrated in certain places, because this graph is measuring both prescription drugs and synthetic drugs and heroin. So in your book, one of the things they talked about was the prevalence of this drug in places like Southern Ohio and West Virginia, and you can see that represented pretty clearly in this map. Our final graph is in regard to the rest of the world. So in this graph, we're measuring countries that have drug-related mortality rates that are unusually high. And as you can see, America, once again, winning by far. So again, this is sort of related to how many prescriptions exist in different countries. It's directly related in regard to prescriptions versus deaths. But I wanted to show it to you to make a point once more of the extent to which this is happening more in America than anywhere else. So you may be wondering, what is America doing in regard to all of these deaths and the fact that it's so much worse here? And the answer is twofold. On the one hand, we have some legal things in place, and on the other hand, we have some medical things in place. So first, let's look at the legal parts. In 2017, Trump signed an executive order which made the opioid epidemic a national concern. I have it here for you. This comes from the Department of Health and Human Services, and basically they have determined that the opioid epidemic is a public health emergency. So this was something that they decided in 2017, and the interesting thing is that it expires after about 90 days, so they have to keep renewing it. In case you were wondering, yes, we did renew it recently. As part of this document, they listed the 5 things that Health and Human Services are most concerned with, And they're pretty interesting. One is in regard to improving access to treatment and recovery services, which is very important. Very often those things are located only in cities, and we definitely need more of them and more in rural areas. The next is promoting the use of overdose reversing drugs. That's one of the things we're going to talk about in a second, the presence of Narcan. The third is strengthening our understanding of the epidemic through public health surveillance. And that means doing studies. This one has kind of fallen through. The current administration has stripped a lot of funding, for instance, from the CDC. And of course, our current epidemic has meant that we are focusing on COVID rather than opioids. The fourth is providing support for cutting-edge research on pain and addiction. Once again, we are no longer funding this kind of thing. And the fifth is advancing better practices for pain management. And very often what they mean here is seeking pain management alternatives that are not opioid related. So we're seeing a lot of really interesting studies lately about different kinds of therapies that can be done and different kinds of drugs that can be used in their stead. So one of the things that they talked about in that document was overdose reversing drugs. The most commonly known one is Narcan, and this is a pretty good drawing of how Narcan works. So basically, if you take too many opioids, the opiates themselves bind to too many receptors, and that's when it stops your breathing. So what Narcan does is essentially fills those opioid receptors and blocks the opiates from getting to them. So even if you've already taken a great deal of opiates, once you take the Narcan, it sort of replaces those opioids in your receptors in your brain, which allows your lungs to essentially start working again. The issue is that Narcan can be very expensive, and a lot of towns are running out of money to fund something like this. So there are a lot of forms of this drug. In these graphs, we're looking at naloxone, which is just another sort of brand name for the same drug. But as you can see, it has gone up in price over the last couple of years. So for instance, in 2012, a single dose of this drug cost $62, and in 2016, it cost $142. So one of the things that we're seeing being questioned in America right now is how much money we should spend on these drugs. A lot of places are seeing, for instance, their fire departments or their emergency services departments spending a huge amount of their budget on these drugs, and people are saying that maybe we shouldn't. Maybe we shouldn't spend essentially so much money on addicts. Maybe we should save it for the people that we consider to be better. So there's a lot of question about what we owe to the people who are addicted to these drugs, and for instance, how many times we should bring back the same person. So the fact that these drugs have gotten more expensive is just another part of the problem with this epidemic. Our next question is it addictive? And the answer here again is yes. So addictive. Basically, the most addictive thing we have invented yet. So again, I wanted to show you this very simple picture because it does a great job illustrating the fact that not only does it block pain, it enhances dopamine. So that's, again, why this drug is so very addictive. A more important question might be, who is addicted? So let's look at that question next. So one of the tricky things about this drug is that it does tend to cross demographic boundaries. So some of the other drugs that we've talked about tend to exist more or less in one place and amongst one kind of person. But this drug comes from doctors. And that means that a lot of different people have access to this drug. It's also important to note that this drug is so addictive that it really doesn't care what your race is, or your gender is, or your location is. So the likelihood that somebody will get addicted to this drug is actually unusually high. We think maybe about 20% of people who take it start to misuse it, and then maybe about 12% of those people develop a serious addiction. So on the one hand, who is addicted to this drug? Could be anybody. On the other hand, who is addicted to this drug? Mostly white men, aged 18 to 25, who live in small towns. So that means, once again, there are sociological factors at play. So let's look at a couple graphs. In this first graph, we're looking at 3 different factors: race, gender, and age. So as you can see under the race and ethnicity graph, far and away white people. This is in part because of access to medical care. The white population is much more likely to go to the doctor, and they're much more likely to be able to afford to go to the doctor, and they're much more likely to get time off of their jobs to go to the doctor. So essentially, the fact that white people are more heavily addicted than other parts of our population does make sense. It has a lot to do with class. The other aspect is gender. Once again, we see more men than women addicted, and this could be in part because a lot of people start this addiction by abusing the painkiller for job-related purposes. Very often, people who are injured on the job end up on this drug and then end up addicted, but sometimes people who are going through surgeries give this drug and then are addicted. So it's not necessarily a surprise that we see more men than women, but it is a factor of interest. The final part is how old these people are. And this one is a little bit unusual because one of the things we talked about last week is that there's not a lot of old meth addicts, but there are a surprising amount of older opioid addicts. And this is in part because you can take the pills, the prescription pills, almost indefinitely, so long as you never raise the amount or the intensity of the drug that you're taking. But when people start to supplement with illegal drugs, when they turn to heroin, when they start seeing fentanyl, that's when they start dying. So we do sometimes have older users and abusers of this drug. You'll notice that the majority of them are still pretty young, 18 to 34, but they do exist all the way up to 64, which is when they become part of a different category. In this next graph, we're looking at the prevalence of opioid addiction among people with mental health disorders. So this is something we haven't really talked about since we talked about tobacco and alcohol, but it is especially common for people with mental health disorders to try to self-medicate with all different kinds of drugs. So in a way, it's no surprise that we see a direct correlation between people struggling with mental illness and people struggling with opioid addiction. So we, again, see this kind of relationship forming with most drugs, and again, very strongly with this one specifically. The final thing to consider when thinking about who is addicted to this drug is its relationship to other drugs. So in this last graph, we're measuring the people who are addicted to heroin who are also addicted to other drugs. And I just wanted to show it to you because even though we're primarily talking about prescription opioids today, the relationship between prescription opioids and heroin is incredibly high. So you'll notice that people who are already abusing prescription opioid painkillers are 40 times more likely to be addicted to heroin. And that is no coincidence. Our next question is it legal? And the answer to this question is a big part of the problem, because yes, it's legal. You can get a legal prescription, you can fill that prescription legally, and you can take that drug legally. The real issue, of course, is with the people who are not taking it legally and the people who are abusing the system to get more than one prescription. So the only graph that I wanted to show you in relation to this question is about where the people who are using it without prescriptions get the drug. So if we look at this graph, we can see that a lot of them are being given the drug for free by a friend or a family member. Some people, about a third, do have a prescription, and the others are either buying the drug from a friend or family member or a dealer, and then we see the small percentage of people who are just outright stealing it. So is this drug legal? Yes, and that's a big part of our problem. Our final question, as always, is it socially acceptable? And again, this one gets complicated because the drug is legal and it's medicinal. In America, we really tend to trust drugs that come from doctors. So is this drug socially acceptable? Perhaps more than a lot of the other drugs we've talked about. Another place that it gets a lot of attention in regard to being socially acceptable is in music. So if we look at this first graph, what we see is the amount of times that prescription drugs have been mentioned in rap music, but this one is longitudinal. So you'll notice that in the late 80s and early 90s, there was very little mention of pharmaceutical drugs in rap music, maybe a little bit about morphine. But right when the Oxycontin epidemic hit, so too did mentions of the drug Oxy go up in regard to this specific kind of music. And then, as you see in the 2010s, it grows and grows and grows and grows. So part of the reason that this drug might be socially acceptable is because people are hearing about it so often in the music that they listen to. Another part of the reason why it might be socially acceptable now is because so many of us know somebody who is addicted. So in this next graph, what we're looking at is the likelihood that you know somebody who has been addicted to prescription painkillers or is currently. And according to this graph, probably about 4 in 10 Americans know someone who is. That, by the way, is not limited to your political beliefs. You'll notice that Republicans and Democrats are equally likely to know someone who's addicted. And the reason that's important is because it really shows us the extent to which this drug crosses demographic lines. Not everybody knows somebody who's addicted to all the drugs, but almost everybody knows somebody who's addicted to this drug. And that's one of the things that's most important about this drug. Our final graph is a question of whose fault this is. And I think this is a really interesting social question because you'll notice that most of people who are asked this question believe that it's the fault of the people who are taking the painkillers, although a pretty significant amount think it's the fault of the doctors who are overprescribing the painkillers, and a few people are ready to blame the pharmaceutical company. So is this drug socially acceptable? Yes, more so than most of the drugs we've talked about. Once it crosses over into illegal drugs, once it crosses into heroin and fentanyl, you could argue that it's less socially acceptable. But again, the biggest problem with this drug is that it does come from doctors, and for so long we didn't know how harmful it was. So that ends our last lecture on very big and very scary drugs, and I'm looking forward to talking about it with you on Wednesday.